takes a lot of work. And if you fall apart anywhere along this titration plan, then get out your pen, because you're probably going to rewrite out a new titration. So this is from Milton Packer, and he sort of put together a hybrid of what you proposed with the cluster scheme and compared it to the conventional sequence. So like we said, conventional sequencing, you start a drug, you start the next one, you slowly titrate over time. It typically takes months or more to get there. He was suggesting everybody start with the beta blocker and SGLT2 inhibitor up front as the first drug, and then alternate ARNI and MRA in terms of where you start it, and then titrate drugs with the goal of getting everything titrated within 3 months up to goal dose, but starting everything within 4 weeks. This is from Stephen Green and work he put together with Greg Fonerow. And this is a bit more similar to what we've proposed with the cluster scheme, where you put everything in a silo and you try to start everything as quickly as possible and then worry about titration later. They were suggesting actually start everything all at the same time. So that's a little bit different than what we proposed with the cluster scheme. But they were saying start everything at a low dose and then worry about titration later. And this is similar to what Sam Straw suggested from the European group, where you start everything at the same time and then worry about titrations later. And that's because a lot of the benefit from these therapies is related to the initiation, and you get less of the benefit from titrating drugs. So it's really more important to make sure people get on at least some of everything. And then titrating becomes more of a long-term goal and less of the direct benefit from the titrate. So this is what was put together between Noel, Jonathan, and myself. And here we tried to group drugs based on what side effects and what titration parameters you'd want to be looking at. So we put cluster A together with diuretics and SGLT inhibitors, and that's because the SGLT inhibitors have very potent diuretic effects, and a lot of ways you use them to manage volume, and you can sort of use them interchangeably depending on what you're trying to achieve in terms of other parameters. ARNI and MRA are put together here in cluster B, and that's because when you're titrating them, you really want to be thinking about renal function, potassium levels, hypotension. And then beta blocker and sinus node inhibitors we put separately, and that's because you're watching heart rates and really targeting heart rate and symptomatic hypotension for titration parameters. This slide was graciously donated by Sandy just to highlight that although we put in small print, the first visit is really nice to have face-to-face, and that's because the cluster titration scheme works really well for patients who are non-frail or sort of optimal. Not the ideal way to titrate medications in patients who are frail, and frail can be the objective thing or a subjective thing, and certainly the face-to-face helps with the subjective frailty. The objective frailty, things you want to think about is how much blood pressure do you have to work with, what is their kidney function like, how old are they, how many medication intolerances have they had in the past, and just your gut instinct of how likely they are to tolerate rapid medication titration. And this is what we do frequently in the hospital as well when we're deciding, are we going to make 1 change per day or 2 changes per day or wait a couple of days between changes. It's really just applying that to the first face-to-face visit. And then as you go forward and get to know the patient better, you can switch more to virtual care, which we've all been doing in the COVID pandemic, but certainly can be used to titrate heart failure medication. In terms of things to think about when you're starting these medications, I just thought we start with this table and then go through a case to highlight some of the considerations. So for ACE and ARB and ARNI, you're looking at very similar things, which is before you start, you want to see if they have any postural symptoms, what their renal function is like, whether or not they're hypervolemic, and how much blood pressure you have to work. So in terms of lab values that would allow you to either initiate or titrate the medications, if their GFR is greater than 30, their potassium is less than 5.2, it's certainly reasonable to initiate the medications. For both of these, systolic blood pressure is over 90 or almost a good place to start. If they're starting under 90, it's really not a great patient to be thinking about using the cluster titration scheme on, but also be a patient where you want to be titrating slower and a bit more closely. And then as you're increasing the dose, you want to watch the creatinine. And we've, in general, most of us believe that if the creatinine hasn't increased by more than 30%, then it would be acceptable to keep titrating. And if the potassium's staying less than 5, you can probably ask them to just restrict potassium from their diet and slowly titrate. For beta blockers, again, you'd look for postural symptoms, but also what is heart rate before they start. And here you're really worried about symptomatic hypotension or symptomatic bradycardia. MRAs, you're looking at things that are very similar to what you would think about for ACE, ARB, or ARNI. Again, that's why they're lumped together in the cluster scheme. And for SGLT2 inhibitors, you want to think about postural symptoms, but also where you're starting from a volume perspective. So if patients are already starting from a volume to plate side, my experience has been that they don't tolerate them as well. If they're starting from a relatively volume overloaded side, it may actually be a great time to start it because it can help you manage volume a little bit easier. The other thing to think about is whether or not their blood sugars are under control. If not, then maybe try to get their blood sugars under control before you add another diabetic agent. And then as you're titrating, look for symptomatic hypotension, volume depletion, and always be concerned about non-euglycemic in patients when you're starting inhibitors. So this is a case just to try to go through some of these principles quickly. So this was a 52-year-old gentleman who saw his family physician for onset of dyspnea and peripheral edema over a 2-week period. His past medical history included diabetes, hypertension, dyslipidemia, and OSA on CPAP. Medications at baseline are important, partially because it gives you a sense of how robust he is. So he is on perindopril 4 and metformin 500 BID, but as you can recognize, this was also getting some of the drugs covered later on. He was referred to cardiology after his echocardiogram, and hopefully my intranet is going to make this run for you. If it looks like it's not moving, that's pretty close to what it looks like when it is moving. So what this shows is severe biventricular dysfunction, and here in the apical 4 chamber, again, you can see maybe moderate severe RV dysfunction, but severe LV dysfunction. And the EF that was reported on that was less than 20%. In clinic, he was describing shortness of breath with relatively minimal exertion, less than 1 flight of stairs, and I called him INWAY J class 3. Examination is significant for a few things. He has some blood pressure to work with just off the top. So blood pressure 130 on 76. He had some peripheral edema, GBP was at 8, he had an S3, all suggesting that he's volume overloaded, which fits with his symptoms. Some crackles at the bases, but the other thing is important is he appeared warm and well perfused and not examining as if he was low output, which may be a marker of subjective frailty that may make you think twice about using the cluster regimen. In terms of blood work, mildly hyponatremic, normal potassium, normal creatinine, A1C was just a little bit on the high side. So coming back to the cluster scheme, so again, for each visit, you want to think about making a change in each of the clusters. And I'm sorry if people have heard this before, but I think it's sort of illustrative. So he came in and he was volume overloaded. So just thinking in terms of cluster A, he was feeling unwell, but he has blood pressure to work with and kidney function is good. So I started him on Lasix 40 PO daily, but I really didn't want to wait forever for his volume to come off. So I gave him instructions to titrate his Lasix if his weight wasn't decreasing or if he wasn't improving symptomatically. He had lots of blood pressure to work with. He'd been on perindopril when he developed this issue, so I asked him to stop his perindopril, wait 36 hours, and start, say, cubitril valsartan at 49/51, which is sort of the intermediate dose. and I also asked him to start carvedilol. So what we did in the first clinic visit is we made one adjustment in each of the clusters with the goal of trying to get them on, again, foundational therapy. So we arranged for follow-up in 2 weeks and arranged weekly lab work just because we were adjusting several things, including the Lasix and the ARNI. So we did virtual follow-up at 2 weeks. He reported good improvement in his weight, down about 8 pounds, and also improving shortness of breath, now able to walk about 2 flights of stairs before he got short of breath. I wasn't having any orthopnea, and importantly, no presyncope. He was checking blood pressures at home and was getting blood pressures of 110s on 60s, and heart rates he was reporting in 70s, 80s. The most recent set of labs before we saw him in clinic, hyponatremia had resolved, potassium levels were still in a normal range, and renal function was essentially the same in spite of making changes with both ARNI as well as the. So in this clinic visit, it sounds like he was closer to euvolemic, if not already there. So we asked him to switch his Lasix to just PRN for weight gain and started a SGLT2 inhibitor at 10 milligrams PO daily. We asked him to start spironolactone at the target dose, which is 25. And that was because he had some blood pressure to work with. He wasn't having any sort of presyncopal symptoms. Potassium levels were good, and kidney function was good. And then lastly, for cluster C, we increased his carvedilol to 12.5. So this sort of highlights where thinking about this in clusters and thinking about each cluster separately can sort of clue you into making more changes than you would otherwise, because it would be very easy to see this guy in clinic and say, well, let's just change your Lasix and start your empagliflozin, and we'll see you again in 2 weeks. Make one change. With the cluster approach, it forces you to think about all the possible changes that you could make and try to make everything that you think is going to be safe for the patient. So we did clinic follow-up at 4 weeks. So shortness of breath was improved, but again, still short of breath with about 2 flights of stairs. No orthopnea, no peripheral edema, some presyncope, but manageable. Blood pressures were a bit lower, now 98 on 56. Heart rate was a bit better controlled at 68. No peripheral edema, DV was flat. Chest was clear, no S3, and still warm and well perfused peripherally. But what was an issue is on his lab work, we noticed his creatinine had bumped up. So before it was in the mid 80s, it was now up to 110. And when we talked to him, it turned out he was still taking his Lasix because he was hoping it was going to help him feel better. So at this clinic visit, we asked him to discontinue his Lasix. I was relatively reassured that his change in renal function was going to be related to his volume status and should improve. So we asked him to just continue his empagliflozin at 10. We finished increasing his Entresto to goal dose, and we increased his carvedilol to 25 BID. So at the end of the cluster regimen, this is where we try to clue in people to think about other personalized therapies that you could think about, and have a table for that later as well. That will. 2 weeks later, blood pressure was a little bit better, his presyncope had resolved, renal function was better, and now he was really at goal dose of all of the foundational therapies. So this is where you can start thinking about what we call personalized therapies, but you can really just think about it as therapies that it's a little bit more selective in terms of who would benefit. So for ivabradine, you want to consider it in patients who are in sinus rhythm with a heart rate that wasn't less than 70 on maximal beta blocker therapy. The benefit from this is within weeks, and we put it at the top of the table because this is one of the personalized therapies where there's potentially mortality benefits in patients with higher heart rates. The other things to think about are digoxin, hydralazine and nitrates, particularly in patients who are self-identified as African American or African Canadian. and vericiguat, potentially in the future, but personally I haven't used myself. He went for an echo 3 months after his optimization. His EF was still in a severely reduced range with an EF 30 to 35%. So I referred him for an 18. Happy to take any questions here.
Yeah, thanks a lot, Rob. That was a great summary and review of the cluster, and then talking about specific case. That was quite helpful. I did have a couple of questions for you. Do you think that there's any, well, first of all, a comment. I might have been tempted, given that patient's A1C, actually to start the EMPA right up the bat and maybe start with a lower dose of furosemide, just because I would get the benefit of both at the same time, get a little A1C lowering and your diuretic at the same time. You might not need as much diuretic to start. So that's one comment. The second, I guess more of a question is, in what situation might you be tempted to start everything? Like they said in that one particular, study or analysis was like, they start everything at the same time. What sort of blood pressure, heart rate, kidney function, et cetera, would make you happy to start everything at once? Oh, I can't hear you, Rob.
It helps if I unmute myself. So
Yep.
it's a good question, and I think your point about starting with the empagliflozin off the bat is a good one, and I think that certainly would have been reasonable. Our heart failure fellow will tell you that I'm actually a bit of a chicken when it comes to beta blockers and initiating them and how I find people react. So I guess my thought process with the Lasix, at least for this patient, was I was going to start a reasonably high dose of carvedilol at the same time that he was already volume overloaded. And because I was holding his perindopril to start his Entresto, I wanted a bit more rapid diuresis. I think he would have done maybe even better with your approach of starting SGLT inhibitor at the start with maybe low dose diuretic if his weight wasn't improving. So I think that would be totally reasonable.
Sorry, go ahead.
So this is sort of the suggested algorithm I think you were talking about, where you start everything off the bat. And I think this was potentially a person where you could think about that because the ARNI and MRA are both going to have renal side effects. I think I'd be mostly concerned about patients where there's a possibility of hyperkalemia, because I think that's the major issue with starting them simultaneously is you won't really know which one is causing either AKI or hyperkalemia, and you'll end up maybe taking 2 steps backwards. This guy was starting from relatively good renal function as well as normal potassium. So I think this is somebody that if you were a fan of this idea of starting everything all at once, this would be somebody to think about it in. But the parameters for me is they'd have to be normotensive before you start. So at least systolic blood pressures over 120s, so you have lots of blood pressure to work with normal renal function and non-frail, at least subjectively, but also probably age-wise. I don't think I would do all 4 drugs simultaneously in anybody over age 70 unless they were one of the very robust 7-year-old ranchers or farmers that we see that look like they're about 50, but say they're 78. So that's what I would think. The case that I presented, I think you could start everything all at once.
Yeah, and I think that most of us, at least in the past, have suffered from only making 1 change. So if we can even move to 2 or 3 changes, that'll be huge. But I think we have to kind of push ourselves to push harder, get as many of these drugs started as quickly as possible. Now, you mentioned your lab frequency, and it was like every week or 2. Sometimes it's kind of hard to get them booked in for lab, particularly right now with COVID. So how are you kind of working around that? Are you saying, okay, well, I'm not as worried if their potassium and creatinine are okay, then I'm okay with a little bit of a longer delay to get their kidney function, potassium levels checked, or how are you dealing with that?
Yeah, so I sort of try to, I think every 2 weeks is probably reasonable for most patients, honestly. I've been quite lucky working with heart function nurses at the Foothills, where if patients are in clinic and they can't get labs done, they will, if you ask them very nicely, they'll draw them for you in clinic and get them done. So that's one way to get an extra set of labs without having to get the patients into clinic. I think it's something we're all struggling with in the times of COVID, and it's certainly not just in heart failure, but it's something that we have struggled with our advanced heart failure patients, where we can't get immunosuppression or anticoagulant levels for our patients. So I think for most patients, if you were getting labs every 2 weeks, that would be sufficient. If you're sort of lucky and you have patients who live outside of Calgary, it's actually usually a bit easier for them to get labs on a more regular basis, in which case, especially when I'm adjusting ARNI and MRA in rapid sequence, I do like labs every week so that I don't get too far behind the 8 ball on potassium or renal function.
Perfect. Thanks, Rob. And I see Kristen made a comment that she agrees with you that she wouldn't start ACE, ARNI, ARB with spironolactone for the same reasons that you commented on. So
I don't know if you can say that though, Kristen, because didn't you train with Greg Fonerell? Don't you just have to agree with him?
Certainly he's not on the call, so I agree with you.
Awesome. Thanks, Kristen. Okay, we'll better move on. Thank you very much, Rob. So we're going to move on to Dr. Sharma, who's going to give us some more information in regards to diuretic therapy. Nakul, we'll leave it with you.
Okay. Let me just, there we go. Can you see the slide?
Yep. Perfect.
Okay. So I have the arduous task of trying to make the idea of diuresis interesting, and it'll be hard considering I'm following Rob, who's already given out all his goal-directed medical therapy with evidence. But I'll say nothing I provide here really has a lot of evidence, and thus I have no disclosures relevant to the topic of just getting rid of fluid. So my case is going to be very simple, but the discussion may, and the discussion following some of the ideas and thoughts I have around diuresis may actually provoke some questions. 76-year-old female, sorry, it's a little cut off there, should be HFrEF followed in CFC, now presents to hospital with increasing dyspnea, weight gain of 8 kilograms, lower leg edema, previously placed on goal-directed medical therapy, now reinstituted because the blood pressure and heart rate were okay to go ahead and do so, but clearly grossly volume overloaded, therefore started on IV Lasix, equivalent to her home PO dose. I believe it was 40 milligrams, so they switched to 40 IV. She gets mild diuresis in the first day, which is what we generally see, but clearly still has lots of volume to remove. Unfortunately, the diuresis plateaus. You get about a kilo or so off, and now you're getting barely a few grams a day. And you're getting frustrated because now the creatinine is starting to rise. What do you do now? And this is where we've all been. We've had to make a decision as to where do we go now. So in the short 15 minutes, I'm going to try and go over a few objectives, those being, number one, define when and why you should double down with your diuresis, meaning what are some strategies you can to enhance the diuresis that you've already started. What do the guidelines tell us? There are some guidelines out there that can help direct us, and you will generally see there is a consensus across the board. What are other methods of diuresis for refractory patients, and how do you define success? So the use of diuretics in heart failure with congestion is pretty, I think for this group anyways, is pretty self-explanatory. You start off on the left being euvolemic, you go on to the right being congested, and you can see it doesn't matter what parameter you use, it's a clear sort of change from left to right. Either it's by JVP, it's by a 6-minute walk test, it's by level of edema in your lower extremities, it's NT-BROC PNP, it's the interstitial edema found on an X-ray. You could do V-scan or a full echo for the vena cava. You can also do a lung ultrasound, look for curly bleed lines, plus minus pleural effusions. So we have a lot of physical metrics to help us with. The when is a very important part, and that should be obviously a clinical presentation or decompensation when they come to the hospital, as it was in this case. But one should never forget that when you get to a plateau phase where you have people optimize on medications, such as the ones mentioned in Rob's talk, you should always take an opportunity to adjust your diuretics based on your state, based on the clinical parameters I just discussed, as well as other parameters such as lab values. And so this is, so I would argue that there's multiple points to take the opportune time to look and evaluate your diuretic strategy. So what are 4 areas in which we can target diuretic strategy? Well, unfortunately, the focus usually is on the loop of Henle, and it's with medications such as Lasix, and those are sodium reabsorptive medications. But don't forget, you have other areas that you can tackle. And I'll show you some slides later on that show that when you actually use other medications in conjunction, you actually get a more effective diuresis. And so other areas to consider are the proximal tubule, and these are where drugs such as acetazolamide and now SGLT2 inhibitors. And I have some early information on the specifics of EMPA in terms of diuresis. With acetazolamide, you're actually getting rid of sodium bicarbonate. You're preventing reabsorption, thus reabsorption of sodium, and therefore getting a diuresis, if you will. There's also, you can attack the distal convoluting tube. We use things like metolazone, we use things like thiazides. This also allows for sodium, lack of sodium reabsorption, therefore increased diuresis. And then you have things such as vaptins or tolvaptan, which was the most common one used. And the reason, those are aquaporin inhibitors. And basically you're just flushing out free water. Very expensive to get, not used very often, but generally fairly effective. So this slide, at least for me, comes out a bit small, but what I wanted to do is highlight a few areas. And so the difference between the European and the Canadian guidelines generally appears that the Europeans tend to use a spot urine diagnosis after 2 hours of attempted diuresis. And the reason why this is they then use that as a way to guesstimate, if you will, fractional excretion of sodium to then determine if you need to double your diuresis or if you actually need to, or you can continue on the current strategy. And so what you'll do is you'll start off with what you think is an appropriate diuretic regime, and this could be between 20 and 80 milligrams, depending on the patient and the serum creatinine that they're already starting with. You're going to start your loop diuretic generally. As I said, this is usually the go-to for most people. You're then going to evaluate after 2 hours a spot urinary sodium, and if it's less than 50 to 70 milliequivalents per liter, you're then going to double your diuretics. Now remember, this is guideline-based, sort of, I wouldn't say robust evidence, but more expert opinion, I would say in some degree. But I will show you there are some there is a trial that actually looked at this more mathematically and actually kind of agrees with what I'm sort of describing here. So you'll continue on to go down this strategy pathway until you get to sort of the second day of your admission, at which point, if you're still getting a stall in diuresis, you're then going to consider adding supplementary agents. And like I said before, combinations work better for most patients than one drug over another. And so this is the snapshot of the Canadian guidelines, and you can see very similarly, patient with heart failure and volume overload. You start with IV diuretics, and then you assess weight change and or urine output. And in this case, the focus is more on weight change. If it's less than half a kilo or less than 3 liters of urine output, you're going to double your diuretic dose. You then may follow up with the addition of metolazone. Likewise, if you're getting adequate diuresis, you'll continue on the current level until you're euvolemic. And if you're getting more, you may consider backing off or continuing or maintaining the current dose. So I did mention a unique sort of tool that was developed, and I thank Rob for passing this on just before our talk here so I could include it in my slide deck. But there is this tool that was validated through Yale, the Yale sort of diuretic pathway. And what it did is it used an equation, a really fancy equation. I won't go into the metrics of the equation itself, but same sort of thing. You were going to do a urine sample, a spot urine sample for sodium at around 2 hours. And this equation here is called the natriuretic response prediction equation. When you use this equation with your urine spot analysis, you actually can see a significant increase in the fraction excretion of sodium as your loop diuretic dose increases. On the right-hand side, you can actually see when you initiate this Yale diuretic protocol, you actually get increased usage of the medication, but you also get increased diuresis and weight loss. So by using this algorithm, you actually can achieve a better diuresis. Now, it is a bit cumbersome because you probably will have to use this equation, but if it were incorporated into an app or actually an order set, it may actually be a benefit for physicians and other clinicians on the ward. So 5 things to think about diuretic therapy before we jump into some different strategies that we can use. So initial dose is generally 40 to 80 BID. It could be higher depending on the serum creatinine you're starting with, but this is sort of a ballpark figure. You're generally going to double the dose, or 2.5 times, if you will, when you're actually trying to achieve a response. You're going to gauge the response within 2 hours. either with urine output, which is generally what we do, or you may look at the weight change, but you don't have to wait till the following day if you get an immediate response. And that's why generally what I'll do is I'll give a dose of Lasix and follow up with the nurse in about 2 to 3 hours and ask how the urine output's been. Don't worry about the creatinine rise, especially if it's marginal. I say sort of between 20 to 50 or 40 to 50 millimoles, especially if urine output is good and congestion is still present. And combination diuretics, as you'll see, actually have significant benefit in those with diuretic resistance. And so this is out of the Journal of American College of Cardiology, and a recent article here published by Cox et al. And it looked at the cumulative weight loss when you took loop diuretics and added additional medication. And what you actually see is, although there isn't a significant difference in the actual weight loss compared to the 3 groups, there is an actual appreciable weight loss based on just using a loop diuretic alone. And so that's the value take-home point, is that if you're running to diuretic resistance and you're upping the dose or doubling the dose as suggested by the previous guidelines, that you should go ahead and add one of these other medications. The most common being, at least anecdotally that I see, is metolazone. And in our heart failure group, we tended to use tolvaptan a bit more in sort of the early years of the sort of the heart failure, advanced heart failure sort of consulting group, but now we've sort of shied away from that, probably due to its expense, although, and also the fact that we have to jump through several hoops to get it. So other strategies that have been used and have been documented for diuresis actually show that I will sort of go through slide by slide, are not primarily what I would say what I would use, but I thought I'd at least present the data. So there is a paper done by Griffin et al., also within the same journal, and within that same actual, just a few pages from the previous article, which was dedicated to diuresis, and it actually looked at the use of hypertonic saline. So they gave 150 mils of hypertonic saline over 30 minutes associated with high dose diuretics, so usually double the baseline, and then they followed to see if there were significant changes. And you can actually see there was an actual, after post hypertonic saline, you actually see a drop in, or an increase in the excretion of sodium. You also see increased urine output and a drop in weight. So I'll look to the group at large here, particularly my other presenters, to see if they've ever used this strategy, but I personally haven't. There's also indirect evidence that you're actually getting diuresis through the use of other goal-directed medical therapy that Rob has already illustrated. And one caveat is that you're getting an early drop in your NT-proBNP, suggestive of probably diuresis or natriuresis, which we know. And so I would argue that this drug is somewhat of a diuretic, although it wouldn't be my primary choice to start if someone was significantly volume overloaded. Same thing with the SGLT2 inhibitor. And you can see here with empagliflozin, after about a day of the use of the medication, now this was more animal model study, you can actually see that there's increased urinary sodium excretion briefly, as well as increased volume loss, or urine volume loss. And lastly, I wanted to end just with a few slides to talk about, and just kind of tying things back to Nowell's talk, that patients with heart failure and preserved EF, they're very difficult to manage. But one of the things you always have to be cognizant of the fact is their volume overload, and you likely will have to use a sort of combination strategy to get their volume under control, or be very good at sort of having the patient adjust when they would use one type of diuretic over another. And so there was discussion about the use of SGLT2 inhibitors. That was Sandeep's talk in the beginning. And there may be some benefit to that, given some of the information I just presented as an early diuretic strategy. So what works for one doesn't always work for all. And that's why I say I don't have robust clinical or research evidence to suggest one strategy works for one particular phenotype. But I can say that if you're diuresing someone and they still are not getting that increased sodium excretion, you likely aren't hitting them hard enough. And that would be the argument I would make for all patients in addition, and then you add on your other therapy. So how would you define that you are actually winning? So when have you doubled down and you've actually gotten success? Well, you've had improved metrics such as decreased FiO2, increased ambulation, decreased confusion, blood pressure is remaining stable, no evidence of low perfusion. You have a heart rate that's reasonable, not tachycardic. Weight loss continues to be consistent, and you're dropping more than half a kilo a day, and your creatinine isn't rising significantly. So I'd like to end there. I tried my best to make diuresis a sexy topic. I hope I did, and I'm happy to take questions.
Thanks, Nicole. That was great. No, I agree that diuretic therapy isn't always considered to be sexy, but it's super important. We have to understand it well, and there are some strategies that some of us use and some of us don't use. So I think it's good for you to go over that with everybody. I did have a couple of, well, one comment at least was in regards to SGLT2 inhibitors. And I think all of us have had this experience, at least in the heart failure groups, is just using that to try to get diuretic resistant patients to be diuretic responsive. And although your slide sort of talks a bit about it, it doesn't really sort of specifically address that issue. But I think many of us have been successful kind of turning patients, rather than using metolazone, using an SGLT2 inhibitor. I don't know if you want to comment on that.
Yeah, no, I mean, we have used it. I remember one particular patient in CCU. I remember in early days, I remember Jonathan off the cuff just said, why don't you give him a whole schwack load of DAPA or EMPA? And we did, and the patient did diurese well. So anecdotally, I would say, yes, I agree that you do get a diuretic response. I don't know if that applies to everybody, but certainly there is some value in considering it as a diuretic in addition to your loop diuretic. I don't know if the others have comments, but I would agree with that statement.
Yeah, and maybe not necessarily for you, but maybe for any of the heart failure people on the call is, does anybody use the spot urine, the 2-hour spot urine? Are you using it? Is anybody using that? And is it something that's useful? Rob, what do you think? Or,
So I was pitching this a while back when I was over on off-service units, and where I found it really helpful is where you didn't have information to work from, and either you were going to wait 24 hours to figure out how they were doing, or you would get an extra piece of information. So like units like 64, where you may not get daily weights at all or ever if you asked for it, I found it quite useful. Or in patients where you're not quite sure, there's like discrepant ins and outs and weights, and you need just an extra piece of information, I find it quite helpful.
So you're not necessarily doing a 2-hour one, you're doing like a spot urine just to say, okay, there's spot urine, it's less than 50, I'm gonna, maybe be a little bit more aggressive on my diuretics, that sort of thing.
Yeah, exactly. So I asked them to try to time the urine to be 1 to 2 hours post the dose, so you get a sense of what the peak spot urine is. I don't use the equation that they were using at the Yale group. I just use the spot urine. And then if it's over 80, I'm more or less reassured that they're going to pee enough, and it's less than 40, then I double their Lasix. And if it's in between, I sort of make a judgment call.
Yeah, I do. I kind of do the same thing as Rob does, or in a really refractory diuretic patient, I'll just check it. But sometimes I will already have doubled the Lasix or added something and then check it, just to, and someone truly diuretic resistant.
Awesome, thanks. Between all of you guys, like if a patient's creatinine is increasing, when do you decide that if their creatinine has gone up enough? Is it just 30% that you will start to back off? Like sometimes their creatinine goes up quite a bit, and they're still congested. So how do you decide when you're going to stop decongesting when the creatinine is going up?
I can try to, I mean, I look at the percentage increase, but I also look at the hemodynamics of the patient. Like, for example, person I dealt with just prior to, getting on this talk here, was their creatinine was going from 280 to 320, but they're clearly congested. So I upped the Lasix, gave a bolus, and added metolazone, knowing that I need to get the fluid out somehow. So it is a little bit of an art rather than a science, where I think, you understand that if you get the fluid out, you may, revert some of the cardiorenal, you may actually get more fluid out and help the patient in the end. So I think you kind of have to have an understanding of your patient's physiology, and then apply that with the ideas here that I presented in terms of diuresis. But I don't think it's a cookie cutter answer that I could just say, oh, at 30% you stop, because I think everyone on this panel is going to give you a different kind of flavor, I guess.
I would just pipe in and say that when you see people who are not diuresing and their creatinine's going up, the most important thing is to reconfirm what you thought, which is they're really congested. So if they're really congested and you really need to remove fluid, then that that usually means that the diuretic has not been the cause of their AKI. It's the other way around. The AKI has been the cause of their lack of diuresis, and so they're going to need more. The second thing is, as Nicole, you said, perfusion. If patients are poorly perfusing, then that has a direct impact on their ability to diurese. Remember, perfusion pressure in the kidney is affected not just by the systemic pressure, it's also affected by the right atrial pressure. And we got to keep that in mind. When they're hypotensive, that gradient goes down dramatically. And when that renal perfusion pressure goes down below 50 or 60, it's not going to work very well. And then the last thing is, in these protocols where you use spot urines, if you're going to do it, and I rarely do it, and I only do it when, quite frankly, I'm really worried about their ability to diurese and they're not in good shape. I should probably use it more often. But before you do that, the protocols stipulate that you should try to get the patient to void, or at least find out if they can void before you do give the diuretic, because if they have a bladder that's already partially filled, and then you won't be able to see the diuresis in its pure form, if you will, the response to the diuretic. So those are my comments saying, oh, one last thing. Make sure that you've done whatever you can to get rid of renal toxins or things that, I've temporarily cut back on ARBs and ACE inhibitors, for instance, especially if they're hypotensive in that setting.
Thanks. There was a comment, and Rob, you talked about using hypertonic saline to good effect. Could you comment on in what situations would you add hypertonic saline?
Yeah, I'll comment on the one specific place where I used it, and that was a patient who was already starting off hyponatremic, who was on Lasix infusion at 20 and BID metolazone and not losing weight. And in that situation, it was really the only option I thought was reasonable outside of reaching for dialysis, which for that patient wasn't an option. So I used it as a last option, and I gave it just as Nicole described, as a single bolus of hypertonic saline that was infused over an hour, and they peed a lot and actually slowly corrected their hyponatremia at the same time. So it was quite effective at the time. I don't routinely use it. I've only done it once.
And just remind me, what dose did you use? Like, was it a 250, a 500? How much did you give?
It was at 100 mils. I think I actually called Jonathan to make sure I was giving, to make sure I was giving the right dose. It's a relatively small dose, but it's just enough to get enough sodium delivered to the kidney to start excreting. Yeah.
So I never used it.
That trial actually used 150 or 300 like an hour, 150 over 30 minutes.
Okay.
I did exactly what Jonathan said, 100 mils over an hour. Yeah.
And is that a reasonable thing to give if somebody's also going into renal failure? Is that something that might help them kind of turn around, or is that like pie in the sky?
I don't think it's a pie
I think
in the
it comes
sky,
back to.
Sorry, go ahead, Rob. Go ahead, Rob.
I was just going to say, I think it comes back to what Jonathan and Nicole were saying about making sure the volume status is really what you think it is, and making sure they're well perfused. So if it's really somebody who's warm and very wet and their renal function is worsening, then I think it's something you could try, but you have to be real sure about their volume status before you would use it if they're in renal failure.
Okay.
We see a lot of right-sided heart failure on the heart failure service, and we see this a lot. And it's less common, but other people, I notice a lot of people on the call see this too when they're on service, and they'll have this creatinine rising, worsening heart failure, but there's a lot of right-sided component to it, and unfortunately, you just need to get rid of that fluid before they're really going to improve. So it really is about the fluid removal in that setting.
Yeah, I was just going to add that I have used, like, I almost tempted to, in this patient I have in CC who's not doing well, like a ultrafiltration just to get that hemodynamic better. He's definitely got high right-sided filling pressure, right atrial pressure. I'm having trouble getting fluid out despite using good inotropic support. I'm mean arterial pressure that's in the 80s, and yet he's peeing only 50 cc's an hour on high dose Lasix and metolazone. So I think there's multiple strategies I think you can use, but I agree, it's getting that fluid out.
Okay, thank you. And so I've got my entire panel up. I've asked a lot of questions to try to pull out some interesting additional pieces of information. Do any other panelists have any other questions of either each other or any other comments you'd like to make?
Well, I'd like to ask if May is willing to give us her video. And she's been working very diligently over the summer. I think really got our processes in line now. We're ready to kind of announce the presence to the world of this clinic and start seeing a little bit higher volume now that we got our processes. May, are you there? Are you out there?
I'm out here.
There you go. That's what May looks like. Any
everyone.
particular comments you have?
Well, first, a quick shout out to Total Cardiology. There were a couple nurses online earlier. They've been really instrumental in supporting my role there, so I'm very grateful to them. And yes, I think we've got a good process down. Of course, we'll continue to learn as we go and start seeing a higher volume of people, but we're starting to get some really great referrals, mostly from the heart failure service and less from the IM and off-service units, but that'll come. We have created documents, one-pagers. One is some information for healthcare providers, and another one is an information sheet for patients that I'm happy to distribute. It's intended to give to patients when they're referred to the clinic, because it is a unique clinic that people should understand, not intended to follow them longitudinally. And the referral form, I think Jonathan has already put up, but I have a fillable version that I'm happy to email, and I'll post my email address for everyone if they want to contact me directly with any questions. And that's about it. I can share some numbers if anyone is interested. We've had about 92 clinic visits to date. 64 of them were initial consults. 23 have gone on to cardiac function clinics. Some come referred from the hospital, and some referrals that I put in if I deem them necessary. 2 have unfortunately passed away, and there are no rehospitalizations that I'm aware of. I cautiously look back at neck hair.
Yeah, you know, and that's an amazing thing, May, because really, you know, rehospitalization is the Achilles heel of discharging patients, and you know, the whole idea of this clinic, and I guess the proof will be in the pudding, is having you in place and kind of capturing these patients early after discharge will help kind of redirect them from being readmitted, and that's part of the goal for sure. Thanks.
Yeah.
And I think it's really great that this clinic is up and running. Thanks to Jonathan yourself for making it happen.
Thank you, Sandeep and Nakul, who have reviewed patients with me. I'm very grateful for the support, and it's been a team effort for sure.
Now we're coming close to the end, but there was one question that I see here from Elizabeth about, can you explain how perfusion affects diuresis a little more in depth? So I think that's for you, Jonathan. Maybe how renal perfusion affects, I think, more than
I was hoping
else.
Nicole would answer that. A couple things. The first thing is, if the kidneys aren't getting blood, they can't make urine. So you have to perfuse them. And ex vivo animal studies, in vivo animal studies, and observational data from humans shows the same thing, that the amount of urine that a kidney makes is almost within limits, is almost directly proportional to the perfusion pressure. And that's within a range, of course. Once it goes really way too high or really low, you know, under 40 for sure, it basically stops. 40 to 60, it's low. Over 60 perfusion pressure, up to about 100 and something, it's sort of linear. And then I can't remember the dates. If there's a nephrologist on the line, speak up. But I think once you get much over 110, 120, then it actually starts to drop again. So you need to perfuse the kidneys, and we often forget that. And sometimes blood pressure, sometimes you have to sacrifice some of your evidence-based therapy that lowers blood pressure for a few days, at least in the doses, and certainly some of the unnecessary vasodilators before you can sort of reinstate them when the patient stabilizes. So those are my comments about it. I hope that is good enough for an answer.
That was great. Thanks. Well, we've come to the end. Thank you. I'd like to again thank our speakers and our sponsors for this evening. It was very well done. We'll be posting this on the Live-In website. In addition, I'm going to get the PDF of the slides so we can share those, assuming all the presenters are good with that. You know, we'll get the survey. We want you to fill that out just to sort of tell us how we did and whether or not there was any other comments that you would make in terms of different ways to present it. We'll try to get that link up right away, and I think Justin's going to get that for you. So please click on that link and fill out the evaluation. Thank you, everybody. And there's the survey. So please click on that, fill it out, and we will have a look at it for any future presentations, which we hope we have another one, maybe a case-based presentation for the next one where it's really just a stack of cases, which would be super interesting for everybody.
That would be a great idea.
Yeah.
Thank you, everyone. I'll email the feedback form as well. And Dr. Eggle on the group can follow up, as he said, with the Live-In website and PDF of slides, etc. So I'll leave that to those gentlemen.